So just going to share one case. This is actually a case of fused dystrophy. It's a 51-year-old lady, and this is a specular microscopic picture. There's hardly any cells in the central cornea. And this is a slit lamp picture of the same patient, and she had even a cataract. So I was planning to do a combined procedure of phaco with the DSEC, and I was just preparing the donor button. So this is an artificial anterior chamber, and I mounted the corneoscleral graft on the artificial chamber, but there was a AC collapse, so I could not create a seal between the anterior chamber and the seal between the corneoscleral button and the base of anterior chamber. So there was a leak actually. I tried rectifying it and even I tried it again and changed the sleeve, tried it again, but there was a leak, persistent leaks. Then I thought I'll remove it from this anterior chamber. This is actually a reusable one, and so luckily I had two more anterior chambers available. This was actually a disposable one, which was actually discarded because I have used it for 11 cases. But this is what was available that day. And again, there was a collapse of anterior chamber, so I could not proceed further. Luckily, I tried with one more anterior chamber. This is again a used one. We used it for more than 10 cases, but luckily I could maintain this chamber. And this is an encasing unit, and I locked it with the locking ring and formed the anterior chamber. So it was a tight seal. I could easily do my dissection as a lamellar dissection from white to white. So once it was complete, I thought I'm lucky I could finish this without much problem, even after having the initial hitch. So I just mounted it on the Teflon block and punched a donor button using a donor trephine. This is a disposable trephine. And this is my lenticle. This is the endothelial surface, and the other one is the epithelial surface. So I did my phacoemulsification for this patient. It's a grade stage 2 fuchs. The patient was symptomatic with the bulle, and I did a phacoemulsification and placed the lens in the bag, and then I did a Desmet scoring using a reverse Sinski. So far so good. And now I just introduced my this is a sheets glide, and I'm just searching for the donor lenticule, the posterior lenticule, but I was not able to trace it. So I was just searching for it, but I could not find it. So what to do now? I don't have a spare button, and it's actually the starting of lockdown, and I cannot expect optical grade tissue also. So there was no button, no lenticule, posterior lenticule. So what to do now?
We can stop here and then we can quickly come back to you. And so you have a problem of, you have already done, stop sharing the screen.
Yeah.
Shreesh?
Yeah, sure.
Yeah, I think you have a problem of DSEC graft, and you're not able to get the DSEC graft there, and you've done already the phaco, and you don't have a spare one. And so my suggestion is just close up the case, put the IOL, already put the IOL, and if at all suture the wound if you want to, and probably take up the patient for DSEC later at the second stage. Quickly, one or two comments from Dr. Ramurthy, Tangavel, and Dr. RDR, Namita, and Rajshekar. What would you have done?
I think what you say is quite reasonable, Mohan. I mean, there's always some of these cases last for some time, and the corneas last for some time with reasonable vision. And whether you do a combined surgery or not, of course, here there was hardly any endothelial cells. So, as a non-cornea surgeon, this is what comes to my mind also. That is, you close the case, and then in case the cornea worsens, then do a second stage DSEC.
Yeah, Tangavel, sir.
No experience. I just close it as you said. I just close it and come out and then.
I think best option is to close it and probably take the patient. What is the reason for that last graft, Shreesh?
I'll come to that.
Okay, we'll come back to that. Okay, right.
Yeah.
RDR, sir? RDR, what you have done?
No, I'll just pass it on. But as you all said, I'll plan for a stage.
I'm sure you'll have a lot of spares in Arvind. No, you can always.
not immediately, though.
Yeah, because there's plenty.
This season everywhere.
Namita.
Yeah, if you're feeling very comfortable and luxuriant as an eye hospital like more Arvind, you can go for another graft. Otherwise, just abandon and take it as a second step.
No, it's not abandoning. You're just closing up the case. You're done the cataract.
You can stop that and then take it up as a second stage.
Second stage, maybe after a month or 2 or 3, whatever it is.
No, we can do it as soon as we get the cornea.
Concur with all of you, sir. Close down with the phaco and stop.
Second day, third day, when you get the cornea, you can do it.
Second day, third day, what is the hurry? You can do it at sometime also.
The patient
no, but he has already removed the entire endothelium.
Yeah.
Endothelium has been removed completely.
Okay, let's come back to Dr. Shreesh and see what he has done. Shreesh, can you start sharing the screen again?
So, I waited for some time, and again I searched. So where could I lose this lenticule? So I tried again. I searched in and around the sheets glide for posterior lenticule because I can't postpone it because it's already removed the endothelium. Descemet's complex has been removed, and the patient will develop a full-fledged endothelioma. Now I could trace it. It was actually a very thin graft, very thin. It is this is a thin lenticule.
Almost like a DMEC graft.
It is like a DMEC roll. So I tried to manipulate it. To my luck, at least I could get this. It's very thin, but handling of this graft is very difficult. I stained this with the trypan blue and then introduced it into the anterior chamber using a glide and Sinski hook. You see in the anterior chamber the behavior of this graft. It's so thin. It may be around 30 to 40 microns. I just closed the chamber and injected some fluid. It just rolls back. You can see the rolling of this graft. It's such a thin graft. And I injected air bubble into the anterior chamber to tamponate this graft. I positioned it. I centered it and put a big air bubble to tamponate it. And I had that followed that half an hour of 100% air bubble in the antechamber, and then I did a ear and VSS exchange. I reduced it to 75% of the antechamber, and then I closed the case. So I was very happy. And but the next day morning, of course, when I saw the no air bubble and this thing graft was dislocated into the antechamber, and there was a dislocation of the graft. This is actually very difficult. If it is a thin graft, if the graft is dislocated, it is very difficult to identify the surface. The orientation of the graft will be difficult.
No, don't you put a marker on the graft?
It is.
You don't put a marker.
Only for DMEC.
DMEC we put, this is a DSEC graft which has become a DMEC graft. So luckily there was some thickness because of the edema, because there is some amount of stromal tissue was there. So it was swollen because it was detached from the cornea, it was swollen, and so I could manipulate it even though it is a very thin graft because of the edema, corneal edema. And I centered it and I put a ear bowl. I filled the chamber. It was a 100% ear fill, and then I reduced it to 75%. And this is the first post-operative picture. You can see the graft thickness. This is just as thick as the epithelium, maybe less than that. So it's around 40 microns. It's like a PDEC graft or a DMEC roll. And there is hardly any corneal edema. Luckily, the patient did very well. This is a 6 weeks follow-up, thin graft, like a DMEC, and patient gained 6x6 parts with a small clinical error of 1.25 diopters.
Fantastic.
So it's not a challenging case, but it was a challenging situation. So I could come out of this challenging situation with the good results. Thank you, sir.
Very good. Very good. First thing is, Shreesh, very, very nicely managed. I want to do two things. So I want to see the horoscope of the patient as well as the horoscope of Shreesh also. Yeah. The horoscope is probably matching very well. And you can stop. Yeah, probably the patient is doing very well. Fantastic. And you are able to, you didn't lose your cool and went ahead and refilled. I was wondering whether the side port was a little too big. You should have put a suture for the left side port. No, it was leaking because you don't want that air to also leak, to a large extent.
Yeah.
When you are refilling it. Yeah, but you've done a fantastic job. And any different take? Can you just stop sharing the screen there?
I have a doubt. Do we always have to let out that air, sir? I put air, but I don't let out air at all because as it is, there may be some leak and air gets lost. So just manage the intraocular pressure in other ways. Oral anti-glaucoma medications or maybe mannitol also I give, but I don't let out air at all. So that helps us with the graft from dislocation.
We can even do a peripheral iridotomy, preferably.
Yeah, that also I do.
Yeah, that also can be done.
That will help actually.
Definitely.
But we have a full.
But letting out air, many times I've seen trouble with that. So I don't let out air.
See, Shreyas, I would just want to ask you one quick question. What is the reason for the dislocation of the graft? Was the air fill not enough for a long time? Number one. Number two, it was probably very thin and we do not know exactly what has happened.
Wrong side.
What is the reason, Shreyas? Can you have a comment?
Yes, sir. Yes, sir. No, sir. Great video, SK, sir. Just that I felt probably the one other challenge which would be in addition to the thin graft is the variable thickness of the graft, which would have been likely because the dissection was attempted 3 times because of the leaky anterior chamber. So you might have had a thicker periphery, but as we went to the center, because we are having to, the chamber is not tight, you're dissecting with a little bit more force and it becomes very thin in the center. So because of that variable thickness also, there is a possibility that the attachment might have a little bit more difficulty. With regards to the air fill, generally I do an inferior PI, but I don't leave 100% fill just like SK sir did. After 8 or 10 minutes, I just make it a 80% fill because last thing we want is a pupillary block, because any synechiae going towards the graft will make it to detach definitely. So I generally have 80% fill at the end of the surgery with an inferior PI.
Okay, thank you very much. I think we have covered that very well, and it's a very challenging situation, but he has managed it so well.